Okay, good afternoon, everyone. Welcome to our fourth echo session. I just want to check if everybody can hear us. If you can hear us, just wave your hand before I start the introductions. Oh, perfect. Awesome. Okay, that's good. Oh, okay, perfect. So we'll go straight on into the introductions before I do a recap of the last three sessions. So we'll start with Lewanika General Hospital. I must mention today they are the presenters of the case. Lewanika, can someone please introduce the team?
Good afternoon, this is Lewanika. We have messages from doctors, student officers, pharmacy staff.
Thank you very much, Lewanika. We'll now move on to Petauke District Hospital. Petauke, are you able to introduce your team? Somebody to introduce the team from Petauke?
Yes, thanks so much. This is Zimbayotam from Petauke District Hospital, Eastern Province. With me here, I have a team comprising of the MO, the accountant, the secretary, dental, and the lab technician. And we are still expecting some more people to come and join us in our team today.
Thank you very much, Petauke. We'll now move on to Livingstone Central. I can see a big team there. Livingstone, somebody to introduce the team. I'm sorry. Can you unmute Livingstone? Can't hear them. Livingstone, let's try that again. We actually cannot hear you even if you are unmuted. Okay, apologies, Livingstone. We'll get back to you once we fix the sound there. We'll now move on to, oh, I saw somebody in Chilenge. Hi there, Chilenge. Somebody to introduce the team. I see you have a new conference room, but I'm told that there's a meeting in your echo room. Please introduce yourself. Okay, I'm sorry, we're getting a lot of feedback from there. I guess we'll move on to the people that we have here. We have Leonard. Leonard, how are you? You're welcome. Please introduce yourself.
Good afternoon, and thank you very much. Good to see you. So my name is Leonard Bikinesi. I'm a specialist family physician from Namibia. Thank you.
Thanks, Leonard. We'll move on to Bruce. Bruce.
Here, and wonderful to see you all. I'm with Project Echo also.
Thank you, Bruce. We'll move on to Makando. Are you able to introduce yourself, Makando?
Yes, hi, hello. My name is Makando Kavila. I'm with SW21 project here in Osaka.
Okay, thank you. I see somebody has moved out of the HW21 room. I was about to introduce them.
I have Brenda.
No, I'm here. My name is Brenda. I'm the HW21.
Okay, that was quick. You people are IT people, so you played with our eyes. Okay, thank you very much, HW team. So Doug, are you able to introduce yourself?
Hi, this is Doug Watson, joining you from Toronto.
Thank you, Doug. I see we have some people on phone. Dr. Muya, are you able to introduce yourself? We see you are with us, even if we can't see you. Dr. Zulu? Okay. Try. Lucy Zulu, are you able to hear us? Hi, Dr. Zulu.
Hi, how are you? Dr. Zulu from UTH, currently not in UTH, but part of the ID team. Thank you very much.
Thank you very much, Dr. Zulu. It's always good to have you. I see we have some people who are on phones like Techno. It's very difficult. If you can rename yourself, it will be a bit easier. I'll try with Livingstone again, our faithful friends. Let's try again, Livingstone. Okay, I think we'll just move on. Apologies, I think we have a sound issue from Livingstone. So our topic for today is TB HIV in adults, but just a quick recap of our previous cases. Our first case was of a 50-year-old male who was due for ART initiation who had difficulties in swallowing. Our recommendations were to give TLD, start INH and Septrin, do a serum crag, and do fundoscopy. Actually, I have some interesting updates on that patient, but I'm not allowed because he'll be represented another day. Then we had a lady, HIV 1 and 2 as our case 2, who was supposed to start ART and TB treatment. On this case, we learned that there's a lot of HIV 1 and HIV 2 cross-reactivity. We need to interpret the cases in context. When we do the test, you need to make sure that it's a dark line. We also have an interesting update on her. We recommended that we use an IUD because she would have a lot of drug interactions with the ATT. She will be presented later. Last week, we had a 6-year-old boy with a high viral load with a very interesting genotype that showed that actually somehow the lopinivir wasn't getting in his system. Our recommendations were the family follows up with a community worker who will see what the family situation is and how the child is taking drugs. What we learned from this case is the importance of sequencing our drugs in a logical manner. We don't want to have sequential monotherapy. So UTH is working hand in hand with this child to see if we can get either lopinivir or altegrava to him. So today we are going to go into our didactic. We have Dr. Duncan Chanda, who has a lot of experience with TB.
Should I go? Thank you, Sambo. Good afternoon, ladies and gentlemen. My role today is just to review a few aspects of TB, HIV, diagnosis and treatment. Can I have the slides up? So as we are waiting for the slides to come up, I should mention that this is quite a big topic, but I've tried to make it as simple as possible and as brief as possible. So probably we could address and focus on the case later on.
Okay, sorry. So the team in the hub, I forgot to introduce the hub actually. As usual, I'm Sombo, and in the hub, I have our team. We have our ID doctors who are always here to support us. We have the team all the way from Adult Center of Excellence. We have a team from Pediatric Center of Excellence. We also have people from the lab, and we have NOMSA as usual, our coordinator who's from HW21. We are also, most importantly, joined by the CDC team. I believe we also have Dr. Simon Agolori, who's the first person I heard about ECHO from. He was saying echoes. I didn't understand what it was about. So it's an exciting day for us. But we'll have the slides up very soon. So apologies for the delay, but we want to say thank you very much for everybody that has submitted a case. We have a lot of cases coming in. It's very exciting to see these cases coming. Would appreciate if you kept them coming, and we'll try to reserve a slot for you as time goes on. And we encourage that we represent these cases. Already from the first 3 cases that we've presented, a lot of interesting things are happening to these patients. So there's a lot of tools that we have here on ECHO that we can utilize to continue our learning. And Nomsa is going to talk about 2 of them, because last week someone was asking me about dolutegravir, and I said, you know, it's interesting, we talked about this last week, and if you go to iEcho, you actually find the topic and you can replay it. So Nomsa is going to talk about some.
Okay, we do have e-learning courses on HIV and TB, and this is an additional resource that you can actually utilize even after the ECHO sessions. You can log in and self-registration on a website, www.lenahealthzambia.org. And you'll find quite a number of courses there.
Thank you. We have the slides now. Duncan.
All right, thanks. By the way of introduction, I'm Duncan Chanda. I'm an infectious disease specialist registrar under University of Zambia School of Medicine. In my other life, I'm a researcher focused in mostly in infectious diseases, especially tuberculosis and cryptomeningitis. Next. Have no conflicts of interest to declare. Next. These are the learning objectives for this session. The first objective is to review TB diagnosis in HIV-infected individuals. The second objective is to identify the recommended TB treatment options in HIV-infected patients. The third is to recognize how to select an ARV regimen in an HIV-infected patient with TB. Then the fourth is to recognize the challenges in managing TB and HIV, including medication side effects, drug-drug interactions, iris, and drug resistance. I think we are going to, before we get to that, we will start with 3 polling questions.
So there are a couple of questions that Duncan wants us to answer just to assess how we are doing. Then we are going to repoll them. I hope everyone can see, and we want to see the answers. Management of TB in HIV co-infected patients with severe immunosuppression, CD4 less than 50, in ART-naive patients. When should you start ART? Oh. Thank you very much for those responses. We'll get back to them.
We shall share the results at the end. Thank you. Is that the second one? You can read for me.
So the second one, the World Health Organization has recommended urine TB lateral flow assay in the following patient groups: pediatric positive patients, adult HIV patients with severe immunosuppression or severely ill to necessitate hospitalization, any patient who is unable to produce sputum, or adult HIV positive patients. So his question is about the urine lump. So essentially, the urine lump test for TB in urine. Oh wow, that's nice. Okay, we're getting some interesting responses here. I like this question because Duncan has something very exciting to announce about the urine lump, actually. We use it quite a lot using Duncan's lab ourselves, so I like it a lot anyway. So we have a third question. Duncan drives a very hard bargain. Concerning DTG, it can be used in TB HIV co-infected patients. The dose can be increased to 50 milligrams twice a day when used alongside rifampicin containing regimens.
Thank you very much. We can get back to the slides. I think, okay. So that's a busy slide. That's a Zambia country profile from 2017 data. Quickly, it shows that 62,000 patients had TB. That's in 2017. Of these, only 36,000 were actually notified, leaving a big chunk, about 26,000 who are not notified. Then the mortality rate, if you look at that, we had about 18,000 deaths arising from TB, which emphasizes that this disease carries a very high case fatality rate. Needless to mention that 3/4 of those were actually HIV-infected patients. So TB and HIV carries a very high mortality and contributes to most of the deaths related to TB. Okay. On the other hand, if you look at people living with HIV, about 36,000 of them actually were deemed to have developed TB. And of these, just about 2/3, 20,000 of them were notified. Though what is probably there is about 18,341 of them were actually on both TB and HIV treatment. Thank you. Let's go to the next slide. Yep, it's not. Okay, thank you. A brief case there to get us going. Female, 28 years old, recently diagnosed HIV and initiated on ART 3 months ago, presents with a fever, a headache, cough, night sweats. She also notes that she has lost about 5 kg of weight over the last 3 months. How would you proceed investigating this patient? I think just keep that in mind. We're going to come back as a discussion point. TB diagnosis in HIV-infected patients is quite a challenge, largely due to a bacillary nature of the disease, and also most patients present with extrapulmonary disease. Added to that are the suboptimal diagnostics. The commonly used diagnostics here in Zambia and pretty much in other countries, it's sputum microscopy, either fluorescent microscopy or otherwise. culture for sputum, blood, or urine, but largely it's a culture for sputum that is commonly used. Then nucleic acid amplification test start as the gene expert, which is we are trying to roll out across the country. Chest X-ray as adjunct diagnostic, and biopsies for extrapulmonary tuberculosis. The Zambian guidelines, will come back to this, recommends gene expert as first-line diagnostic in HIV-infected patients. There's another aspect of DRTB diagnosis. So both TB, HIV, and the suspected drug-resistant TB, the certified gene expert MTB-RIF is the first-line diagnostic, and WHO recommends a repeat expert for DRTB diagnosis. That's for rifampicin. We know that the gene expert is only able to determine whether one has rifampicin resistant or not. This is also dependent on the prevalence of rifampicin resistance in the community. I think we probably want to discuss that. In our Zambian algorithm for drug resistance diagnostic, it's recommended after the expert, one has to do second-line LPA and DST and first-line LPA. This has to do on how we are going to choose the drug-resistant TB regimen. Cultures are still available where this can be done. I think about 3 centers in Zambia, solid culture and liquid culture, with liquid culture obviously being favored due to the shorter turnaround time. To put our discussion in context, as we look at 1990 goals, in the context of TB, what are we talking about? Okay, so then in the first 90, we are saying that all TB patients, they need provided initiated counseling and testing, immediate ART initiation, which we'll be discussing further, and of course, cotrimoxazole prophylaxis, TB being a stage 4 disease staging. In the second 90, we expect all TB HIV patients to be on ART besides the TB treatment. If the patient didn't have TB, however, we expect these patients to be on isoniazid prophylaxis. At the third 90, all patients should have their viral load monitored according to the guidelines. Next, please. When it comes to treatment, TB HIV poses quite various challenges, including drug toxicities, drug interactions, and also special populations, which we are not going to go into detail, but if people have if there's need to discuss, we could, looking at children, pregnant women, drug-resistant TB, drug-resistant HIV, and HIV-2. So our current first-line ART include TDF3TC and efavirenz, and the TDF3TC ETG. So most sites are using TLE, and with efavirenz as a preferred, in the first line, efavirenz is preferred in people with TB and not nevirapine, due to the hepatotoxicity, which nevirapine and the other TB drugs would share. And if we are using a TLD, I think we're going to have a discussion on this. The dose is increased from the 50 milligram OD to 50 milligrams twice daily. For second line ART, for the sake of this discussion, no, let's keep on that. For the sake of this discussion, we'll just talk about what is available in second line. Largely, we won't use drugs that like atazanimab, but to use loperamide, which you have to double boost in adults. But this is not a practice in pediatrics, to my knowledge. We'll leave out third line ART at this stage. Next. So here are a few points which which are key to this discussion. All patients with TB must be offered HIV testing and counseling. ART initiation in TB patients must be done as quickly as possible. Usually we want to say when they're able to tolerate the TB treatment. Special care must be given to people with very low CD4, particularly people with CD4 less than 50, as these are at a very high risk for mortality. Zambian guidelines recommend GeneXpert as first line for TB diagnostic tests in HIV positive people. WHO also recommends TB LAM in severe immunosuppression. I should mention that I just noticed we also included this in our latest TB manual, TB LAM. I can discuss that further. Then, yes, so basically I think I'm trying to say the same thing even on that point. I think that's all I would like to share at this point.
Thank you very much, Duncan. I see we've been joined by PCOE. They are right in the building. We've also been joined by Nangongwe. I'm so excited to see you. I know last week you tried. Hi, Nangongwe. Can someone introduce the team? Perfect. Hi. It's good to see you, really it is. I see we are joined by Senanga. Senanga, you are welcome. You can hear us, just a quick wave. Sound. Okay, so I see also Dr. Maria M. Tonga from downstairs has joined us. So all of you are welcome. So just before that, so Duncan has talked about TB. We should offer all patients with a presumptive or a confirmed diagnosis of TB and HIV test. All patients should be put on ART if they are HIV positive. And when we are giving ART to our patients with TB, we need to make sure that there are no drug interactions. So we recommend TLE 400, TLE 600, or TLD, which you have to give at 50 BD. The other option is lopinivir, which you have to double boost. So at this point, we'll get some contributions or questions from our spokes. Yeah.
Repeat it.
Mm-hmm. Maybe after
the discussions. Okay.
Anyone with a contribution or a question, we can just raise our hands and we will unmute you. Okay. Is there a question?
I see none.
Any questions from the hub? Any comments from the hub? So Duncan, are you saying that we are going to get urine LAM for our patients?
Yes, so we have included the urine LAM on the TB algorithm for particular patients who are HIV positive, who are severely ill. As you may be aware, the sensitivity of LAM, utility of LAM is in patients who have a very low CD4. Less than 100 or less than 50. We did demonstrate through a MOH country, RCT, with UTH as one of the sites, that we are able to, if you use LAM in this group of patients, we are able to rapidly initiate people on TB treatment. And there was a reduction in terms of mortality of about 4%. You know, within hospitalized patients, TB mortality is around in the range of 40%. So even if you look at the numbers in sub-Saharan Africa, how many TB patients you have, and how long it takes to do the diagnosis and get someone on treatment, getting a rapid test such as a urine test, which can do in 25 minutes on the bedside, can really help in terms of identifying these patients at risk for death and try to get them on treatment early. I don't know which of USAID supported partners, but I know I've already acquired the strips, and they should be in the country anytime. And then we are going to realign our diagnostics to include LAM. We are working on the SOP right now, the National TB Program, so that we can advise on which people LAM would be useful.
Thank you very much, Duncan. We'll now move on to our case that is from Lewanika. Lewanika, are you able to share your screen at this point? Okay, so Lewanika has started, and yes.
That's not the one.
It's okay. I think we'll use this one. It's okay. It's okay. We'll talk about the changes. So Lewanika, we can clearly see your screen. Thank you very much. So please go ahead and present the case. We have unmuted you.
Good afternoon. I'm Precious Hajimula, presenting the case from the Lewanika General Hospital.
Good afternoon, Precious. We can hear you.
Today we are with a case with TB. Yes, thank you. I think we can go on.
Yes.
Yes, we are looking at a case of a female 36-year-old who was diagnosed with HIV in 2015 and at the same time had otitis media. Initially, they declined ART until 2018. They presented with shortness of breath and cough on different occasions from 2016 to 2018. In 2016, she had the smear positive TB, which was treated with category 1 of ATT. Smear was on the same regimen came out negative. There was a noted history of poor compliance to TB medication and also hospital reviews. She has been treated for recurrent episodes of anemia during her follow-up visits. So from the summary of what has been happening from 2016 to now, in 2016, there was smear positive of the sputum and was treated with category 1 rifampicin. They had issues of poor adherence, like I've mentioned. In July 2017, on the 21st, lab results of creatinine were at 94.4, urea 3.2, creatinine clearance was at 89.6, AST was 148.6, ALT 207.9, the CD4 count was 83 cells, and gene expert was showing resistance to rifampicin. Then the treatment which was given was kanamycin, levofloxacin, and ethiolamide, cycloserine, and pyrazinamide. The patient was not admitted because they refused, but they assured him. In 2017 August, her weight at the time was 60 kg. MTS was done, showed positive. MTB was also isolated, a complex isolated. DST showed that streptomycin, rifampicin, and ethambutol were susceptible. And treatment was also given, which was kanamycin, levofloxacin, ethiolamide, and cycloserine, together with pyrazinamide. So in January 2018, AFT results showed 5+, ALT 169, AST 207, creatinine was 133, urea 9.3, creatinine clearance was 53.2. Treatment was given, which was levofloxacin, kanamycin, ethionamide, cycloserine, and pyrazinamide, plus TLE was initiated. So later, kanamycin was reduced, which was to be given on alternate days. Levofloxacin was also to be given on alternate days with the same dose of 750 milligrams. Pyrazinamide was 750 milligrams once daily. Cycloserine was to be given at 750 milligrams once daily. So the patient was discharged against medical advice in January to receive DOT at nearby facility. In April, AFP was done, which came out positive. Her viral load this time was, which was done, it was 610, 696 copies per mil. CSF was non-revealing. The treatment then was continued, but we dropped cycloserine due to the side effect. And when you look at the clinical course, they had diarrhea, hallucinations, visual disturbance. There was unclear, the patient was still on ART, but we were unsure whether they were taking or not. But sputum then was submitted. In May 2018, cycloserine was reintroduced.
Hi, Lawanika. Unfortunately, I think we've lost you. Hi, Precious.
We can't get them.
We actually cannot hear them. Okay, I think we will. Oh, are they back?
Are they back?
Lewanika, are you back? Now you're gone. Maybe you can type something for them.
Sorry about that.
Perfect. It's okay. It's okay.
Yes. The treatment. Okay. So the treatment which they are on is cycloserine 500 milligrams, ethionamide, levofloxacin, pyrazinamide, and also B12. Then kanamycin was dropped from the regimen that they were being given before. So right now the patient appears well and they have gained weight to 65 kgs. All the vital signs are normal. And the latest lab results that we have received today are ALT 7.4, AST 23.1, creatinine is 122.8, urea is 4.85, and creatinine clearance is 57. Okay, so the question that we have for the case here, the first question is, when should one stop the injectable drug in view of delayed sputum results? That is in the absence of the sputum result now. Then how long one hold off a second line medication based on side effects identified? And our last question is, does this patient qualify for TLD based on viral load despite these anti-TB drugs being given?
Okay, thank you very much, Precious. At this point, I know we had a bit of a hitch, and I know the slides were a bit, because this is a case of multi-drug resistant TB. For now, rifampicin resistant TB at that. So if we have any contributions, any clarifications from our spokes, I think we'll take them now. Okay, I think Duncan has a few questions.
Is that on? Precious, thank you for that case, for this case rather. I have a few questions and that I need you to clarify for me. One is, I noticed the patient was on TB treatment in 2016. What period, from which timelines are we talking about? Precious.
Okay, it looks like we've lost them again. So I'll just quickly summarize that case because I think it was quite a lot.
Yeah,
essentially, we are dealing with a 36-year-old female who had actually presented with an otitis media in 2015. She was offered HIV testing. She was actually positive but declined to take ART until 3 years later. She's been in and out of Lewanika General with shortness of breath, a bit of a cough here and there, and had a smear positive TB in 2016, which was a year later after HIV diagnosis, but she was not on ART. So it seems that she actually managed to get a negative smear 2 months into that. However, the healthcare workers noted that she was actually not adherent to her treatment or her appointments. So in 2017, she seems to have come back with quite a low CD4 of 83, and her gene expert showed that she was actually resistant to rifampicin. So they went ahead and put her on what looks like an individualized MDR-TB regime with kanamycin, levo, ethionamide, cycloserine, and pyrazinamide. However, she refused to be admitted for the injectable, which is kanamycin. So she went on her way. She came back in August, and it seems that her doses were adjusted for some reason. I think when I spoke to Western, she seems to have developed some hearing issues. So they gave her alternate dose of the kanamycin and maintained the other drugs. At this point, they had actually sent sputums for microscopy to the TB lab. These results were actually gotten only in 2018, and they showed that actually she was growing TB, Mycobacterium TB, but it seems that it was sensitive to streptomycin, rifampicin, and ethambutol. When I saw this, actually, I thought it was resistant to strep and rifampicin and resistor. I think Precious will clarify that. So anyway, as she's moved on, it seems they've managed to keep her in the hospital at the moment. At some point in 2018, she actually needed to be discharged because she wanted to go home and said she would get her dots at a nearby facility. When they came to see her in April 2018, she seems to actually not have been on ART because her viral load was 610,000 odd. And she was actually confused. She was hallucinating. She was having diarrhea. She was having visual disturbances. So they were forced to drop the cycloserine, and they were not sure if she was on ART. So they went ahead and did a viral load, and it was very, very high. They got her back on treatment and switched her in August to abacavir, 3TC, and lopinavir. By the time they did another viral load in September, she had actually gone to 307 copies, and the CD4 was improving. It seems some sputums were submitted, which they kept on waiting for to see what is the resistance pattern. So at the moment, as of now, she seems to have gained weight. She's 65 kg. She's still in the hospital and is now on cycloserine, ethionamide, levofloxacin, pyrazinamide, and B12. However, as of this month, they've dropped the kanamycin because they could not wait any longer for the DST result. Precious, is that close? I think we've lost them. So do we have any contributions or clarification? We seem to have lost Lewanika. Any clarifications as best as Duncan can do? Since we don't have the...
Are they on?
Lewanika? Edgar, please go ahead with your question. So Edgar is one of our mentors, actually. He's a clinical mentor from Province, from Southern Province. Edgar, please go ahead. Edgar, we've unmuted you. Please go ahead with your question.
Good afternoon, doctor.
Good afternoon.
Hello,
Edgar.
good afternoon. Yes, thank you. So it's unfortunate that Lewanika is off, but I wanted to know on the first management of TB, that is in 2016, if sputum at 5 months and also at 6 months was done, because they just mentioned that the patient had poor adherence to treatment, but they didn't mention of any follow-up on sputum after the 2 months, which was mere negative.
Yeah, that's the question I was trying to ask.
Hello?
I wanted, yes, I'm saying, unfortunately, they are the only ones who can answer that, because they didn't even give us the time period. When was the patient treated? Was it from January to June? Or was it from June to the next January? And then, of course, we only have that information about one sputum conversion. Yeah.
Yeah, Edgar, I think that's a very good question.
That's a very good question. Yeah.
But unfortunately, it looks like they really tried in the beginning, then they sort of lost her. So is there a question?
Assistant, can you write to them?
Any questions from the, oh, there's a question here. Hi, sorry, it just says Zulu. Hi, Zulu. Is Zulu? Please go ahead with your question. Thank you for joining us. You're welcome.
We're not hearing her.
I'm sorry, Hi, Zulu, we actually cannot hear you. I've unmuted. Sorry, Hi, Zulu, I think it's a problem.
I'm Lucy Zulu from Japaigo.
Hi, Lucy, how are you?
I'm good, and you?
I'm well, thank you. Thank you for helping us with the forms. I got the corrections for the TB part. Please go ahead with your contribution or question.
My question is, the patient was near positive. I wanted to find out from Lewanika if they did contact tracing so that we can ascertain that the families that are coming from, the patient is coming from, is safe, since this patient is even resistant, a DRA patient.
Thank you very much, Lucy. Duncan, would you like to speak to that since we don't have Lewanika? How important is contact tracing in drug-resistant TB?
So even in drug susceptible TB, it's recommended in the program that we do tracing, so that in drug susceptible TB, particularly we get to the homes and we can put children and adults at risk on prophylaxis. Okay, like children under the age of 5, they're supposed to go on INH prophylaxis, and I think if you looked at that slide at the beginning, I think we had a very low number, 3.6%, meaning we're not doing very well. In drug-resistant TB, this becomes more important that we actually do get to their homes and screen all those who are at risk and take appropriate action. I know that here within Lusaka there are teams which do that activity, the community-based organizations who have to do that. So Lucy's question, yes, is very important, and I wish Lewanika could actually come back online and then answer some of these questions.
Okay, yeah. So I think we'll just put it in our recommendations if they haven't done it. So Livingstone has a contribution. Please go ahead and read it.
Is it possible for the viral load to drop to undetectable levels within 30 days of changing to second line?
So that's a question from Livingstone. The good news is that we have a team here I know there's somebody who's part of the steering committee from TLD. Are you able to put up the slides again? I think there's a question on, is it possible for the viral load to drop within 30 days?
30 days. It's after
Dr.
switching.
Sivile, do you mind helping us with that?
Yeah.
So just where we had the viral load dips, though I think we don't have it on this slide. So is it possible for a viral load to drop from, I think it was 250 to undetectable within 30 days?
It was 600,000 in April.
Then it went to 307.
Then it went to 307 in September. Okay. But I think there's another figure in between which we haven't put up
250.
there.
They said 250.
Yeah. Good afternoon, everyone. I'm Sivile. I think the simple answer to that question is a yes. Yeah.
What about
possible, especially with TLD? Yeah, so that's possible.
Okay, so that's our answer. How long do you think it would take for TLD to drop it? What timelines are we talking about? What will we be seeing on the ground now that we are using TLD?
Yeah, so from practice, I've seen something as quickly as probably a week and a half, but I think we'll be thinking of maybe a median time of about a month. Yeah.
Would you like to speak to the issue of adherence and dropping of this viral load very quickly? You saw it was in 600,000, then it came to 307. What does this say about adherence?
Yeah, anyway, probably I think we would have loved for Lewanika to be around here. I think at the first issue, just from the onset, when this patient was diagnosed, apparently seems to have had some adherence problems that they should have been handled. This patient refused to be on ART at diagnosis, reason unclear, and would have probably wanted to hear more on that one. But from what we've gotten, the little we've gotten from the history is that the patient eventually improved in terms of adherence, which is probably a plus on the people who are managing the patient. Yeah. So the patient should have been taking the drugs well for the patient to suppress that quickly. Yeah. Obviously, another point of discussion is this is a patient on TB treatment, MDR TB treatment not suppressed. Such a big drop of viral load with a CD4 count, which was extremely on the lower side. Issues of iris, is it a big concern in this patient? Yeah, but I think the discussion might not be complete without the people managing the patients being here.
Thank you very much. Just to take it back to you, you may answer the third one. Is she a candidate for transition to TLD? Was their third question. Are you able to address that one? She's now undetectable. Is this lady a candidate for TLD transition?
Probably no. Yeah, I didn't follow the history completely, but I think this patient at some point was on abacavir, right? Was switched to abacavir. So if someone failed abacavir, one would think of some failure also to tenofovir. So probably TLD has tenofovir in there, might not be one of the good options in this patient.
She's actually currently on abacavir.
Currently on abacavir.
It was made in August.
Was switched
from TLA to ABC, 3TC, and lopinavir.
Oh yes, if the patient is suppressed. Okay, sorry, I can't read from where the T screen is. Yeah, so if the patient is suppressed and is on abacavir and alluvia, isn't it? Yes. Yeah, so the patient can be switched correctly. Yeah, so this is a patient probably who, in the transition, we've said we would love for such patient to be switched with adherence problems. Maybe a 1 pill a day would help the patient. Yeah.
Thank you very much, CV. There's a question.
Okay, Leonard has written in the chat. Yes, very possible, though not common. In my experience, I've seen 4 patients who went from LB5 to TND in less than a month. I need clarification on that second line switch.
Okay. So the second line switch seems to have been made when she came in with a very high viral load. It looks like she was not taking her meds. So that's how they went to a backup of 3-TC lopinivir. If you heard her correctly, they said this lady has been in and out for anemia. I assume that's why they avoided the AZT. So they didn't do a full switch. Please go on. Go on. Leonard, are you able to speak?
Yes, Sombo, thank you very much. I hope you can hear me.
We can hear you very well.
Yes, thank you very much. That's an interesting case. Maybe just to reiterate my comment on that I wrote on the chat. So it's very possible for someone with a log value of 5, even log value of 6, actually to suppress. I've seen about 3 or 4 patients in my experience. So in terms of my question, which I needed more clarification, is that she was switched from TOE to abacavir 3-TC lopinavir in the presence of high viral load. So I was wondering what was the rationale of that, considering that the mutation of TOE and of tenofovir and abacavir are almost the same. Essentially, we're introducing lopinavir in that case, being PI. And the other thing is, when I was looking at the viral load, maybe I didn't get the other one, is 307, which is the latest. There's quite a lot of evidence coming up now that a viral load of greater than 200 especially might be associated with some resistance or mutations. So those are my concerns on that case. The switch, first of all, to me, it was just essentially changing one drug, which was efavirenz to lopinavir, and I'm not comfortable with the viral load of 307 to then move it to dolutegravir. Thank you.
Thank you very much, Leonard, for that observation. I think what Leonard is trying to bring out is that we need to avoid sequential monotherapy. If somebody is on a tenofovir-based regime, if you are switching for purposes of failure, you need to avoid the abacavir because they are essentially the same animal, so to say. However, maybe they were hard-pressed because the lady seems to have had anemia on and off, so maybe that's why they avoided the AZT. But what Leonard is saying, if you are switching from tenofovir to abacavir for failure, you really have the same mutation patterns. So this should be avoided. But that says, I'm not sure, Leonard, maybe you did not hear, this patient is actually now undetectable. So it looks like this regime is working, maybe because this switch was a bit premature, because she actually was not taking her drugs anyway. So that's why the abacavir seems to be quite active. Is that helpful? His hand is up again.
Yeah.
There's an answer for you.
Okay. So Lewanika has an answer for you, Leonard. Thank God. Hi, Lewanika, please go ahead.
Are you reading there?
First, they asked the question, creatinine clearance was high at 1,200. And then now they're saying most recent creatinine clearance was 53 mils. Full dose TTF too high, unless creatinine clearance has recovered.
Okay, so that's a clarification why they moved to abacavir. I think there was renal dysfunction. I guess that, and coupled with what Leonard is saying, is why maybe this choice in the regimen. Is there any other comment or contribution, Tatonda?
Yeah.
Okay, is that Lewanika there back? Okay, Duncan, do you want to talk about the other 2 questions?
What are the questions were? Yes, concerning the injectable, I'm not sure Lewanika can get us. My first question was, how long has the patient been on kanamycin? Lewanika, how long has the patient been on kanamycin? Okay, in the interest of time, I was trying to estimate here. Looks like
kanamycin from August to December.
From August to?
August to? And then the patient reported. I'm not just sure exactly when the patient reported. And then from August to somewhere in September. And then when she came back in January, that's when we found that she was sputum hyper. And we restarted the treatment. Until the beginning of November.
Can they? Okay. I think they can type that for us. Yeah.
Okay, tell us.
Okay, so the first comment was the switch to lopinavir was due to psychiatric presentation. That's the first comment. Then I think answering the question from August to December.
Okay, so I think what we are presented with here looks like the patient was on kanamycin from July 21st, to be specific. It's up to January. Okay. Then from that time, I think they had one AFB negative smear, and then I don't know, the kanamycin was reduced in January to alternate days. Were there issues of toxicity? Or is that the one where you are referring? No, here I can see the creatinine clearance was 53 and creatinine was 133. I'll just guess that's one of the reasons you wanted to put on alternate days. Yes. Then in my opinion, I think looking at the results you had here, at this point you already had this, a positive smear. So, and the patient was on an individualized regimen. You could have dropped kanamycin but replaced it with another drug, which other options now we have. This year, I think about this time we already had other options. And given that this patient was, I didn't see the sensitivity for isoniazid, but this patient would have probably benefited from high dose isoniazid. So basically, yes, you could have dropped the kanamycin given the toxicity issues with this patient, and you could have continued with an alternative drug. I think I could answer the other question as well. How long do you hold off? And I noticed that you held off for cycloserine for a very short period of time because probably you didn't have a lot of options. Cycloserine, others you can withdraw and take it back, but probably you don't want to do that to a drug like kanamycin, which can end up with permanent ototoxicity and deafness for the patient. This is part of the history I would have appreciated. How's the hearing in this patient? We have just been we've got some highlights on the renal function issues, but nothing on the hearing. For me, I think that's a very important part. Yes, you can hold out those drugs which don't have permanent damage and reintroduce them if they're tolerable. In this case, looks like cycloserine was tolerable, but then this patient had issues with the hallucinations, which also you could also attribute to efavirenz. Okay. But looks like you chose to drop cycloserine and they only dropped off efavirenz how many months down the line? 3-4 months down the line. Okay. And by that time, cycloserine has been reintroduced. So for me, I'm not seated there, and I would appreciated a more detailed history. This patient seems like he has been an outpatient on most of the times, okay, with adherence issues both for TB treatment and for HIV medication. And in April 2008, was a patient admitted? Was a patient an inpatient in April 2008?
Like she was because of the hallucinations.
Yeah, because one of the explanations we are seeing the drop of the viral load could be that the patient was in hospital for 2 months, and the patient was actually now getting medication under supervision. I'm just guessing, but that's kind of thing I would expect. And not only that, the last time I visited Mongu, I noticed that MDR patients are inpatients. So I'm wondering, these patients seem to be issues of outpatient, inpatient. So basically, that's how I would answer those questions. I hope I was clear enough.
I think you were clear. There's a comment, a contribution from...
So they were answering your question. They said, yes, she was.
So she was admitted. It looks like this lady developed hallucinations, psychosis, and you can imagine being on efavirenz and cycloserine.
Yeah.
I think, well, by the way, Precious, your team, well done for managing to bring that viral load down. Yeah. It's very difficult. So currently we've been transitioning our patients, our male patients, in the MDR-TB to TLD. We really need to optimize their ART. And it just shows you that if we do not handle drug-susceptible TB very well, it becomes complex. Even here, where we are at a center of excellence, we are having challenges with MDR-TB. But there's one result that Duncan was concerned about that we haven't managed to get to you. Things like your drug resistance. I know you've been submitting sputums to the labs, and that has added an extra layer of challenge for you in managing this patient, because without a proper drug sensitivity, it's very difficult to manage these patients. But I know, Lucy, would you like to comment on this situation? Leonard, please go ahead as Lucy prepares to comment.
Asking what the viral load is.
Leonard, the viral load is actually undetectable on Abacava, 3TC, and Lopinivir. They dropped the efavirenz because she was getting hallucination, which could have easily been from the cycloserine, and the creatinines were very high. They were reaching the thousands. Her creatinine clearance was less than 30. So I think there's a lot going on. There's unsuppression. She's poorly adherent, high creatinine. But looks like they've done a good job in getting her to getting some weight to suppression. But I think, Lucy, would you like to comment on this? Because Lucy works in the TB program.
Yeah.
Especially in terms of us not taking results back to the turnaround time for sputums.
Thank you. I think the turnaround time for the sputum, it depends on where they are getting the results from. But for Lewanika being a general hospital, we expect that they are able to do to get the results within time. But I wanted to know exactly what results are they talking about. Is it gene expert? Is it culture and sensitivity? So I wanted to know exactly when they are talking about the sputum results, which results are they referring to?
Are they there to answer, or I can answer? So basically, the last sputum they sent, they got a smear result, and they are waiting for the culture results. That's my understanding. That's what I can read through here. But I should mention that for this patient, seemingly the only culture and DST the patient had was at baseline last year. And then that's when the gene expert was, the basis for the diagnosis for drug-resistant TB was the gene expert. Having said that, this is the time prior to our updated TB guidelines. Let me just quickly allude to that. The current guidelines are partially based on the WHO recommendation. For TB HIV, for HIV-infected patients suspected of TB, the first diagnostic recommendation is the gene expert. All right. For suspected drug-resistant TB, the first diagnostic is a gene expert, followed by second-line line probe assay. And the logic there is for us to decide in our setting whether we're going to use the short regimen, or a short treatment regimen, or we're going to use individualized regimen. Okay. Also, alongside these two important tests, one would also do a phenotypic DST or first-line LPA. The first-line LPA obviously will give you rifampicin and isoniazid resistance, which helps again on whether in your regimen, in your short treatment regimen, whether you can use high-dose isoniazid. So I think going forward, what we want to see is the kind of cooperation between the clinic and the lab, which I'm afraid at this point, the clinic seems to have really struggled to get results from the lab. We'll try and follow up that. And then we'll also try and, depending on what we find in the lab in terms of results, we might have to adjust this regimen slightly. But then this patient is on month 20, I think, of treatment, and I'm hopeful that the pouches have cleared and the smears have cleared, and the patient is going towards totally being cured of TB. HIV, we have to look into this very carefully. If my bet was correct, saying that this patient started taking medication when he was admitted, that's why there's viral suppression. That's good news. Then there's probably very little else we can do other than adherence counseling and making sure that this patient sticks to the drugs. I know there was a recommendation on DTG, but then I also look at her age. She's 36. How many children does she have? Does she want to have more children? We didn't get that coming out very clearly. So that's an issue we want to address before you switch to DTG. The patient looks like she needs a lot of psychosocial support. Please let us bring that on board. We have a clear history here. The patient was diagnosed in 2015, and we only got her to get on treatment in 2018 for her HIV. I think it's quite a difficult situation.
Are there any comments? Okay, so Doug, I don't know if you would like to comment on this. I know you are really giving us your time, and we appreciate. Zambia is currently transitioning its patients from TLE, I'm sure you're aware, to TLD, and there's been issues in terms of women, should we transition them or not, who gets TLD, who doesn't. This lady is a 36-year-old woman, and they were actually thinking of transitioning her. But as Duncan has said, she's 36 years old. And I don't know how common pregnancy is among the MDR-TB patients. I know there's a study that's been done that they actually do for pregnant, even if they are on MDR-TB treatment.
I know for drug-sensitive TB patients, but on a cohort, we followed up over 2 years. I think we ended up about 15 to 20%. So pregnant. They do get pregnant, isn't it? So we can't just push that aside. I don't know, Doug, would you like to say something about dolutegravir in women, 36-year-olds?
Well, you know, the shorter answer is we don't have all the answers. The data from Botswana was very concerning. Follow-up data since then from sort of a number of sources have not confirmed it, but the numbers have not really been large enough to be able to say no. The Botswana study was done fairly well. So I think it is concerning, put it that way. I think it's concerning. Does that mean we don't give dolutegravir to women? Well, no. There's a reason why you're switching to dolutegravir, or the world is switching to dolutegravir as the mainstay of HIV treatment, because it's extremely durable, extremely powerful, well tolerated, and safe. With this question of whether it might cause birth defects. So I think it's a relative, it's a question, it's a relative contraindication, giving it to a fertile woman. I shouldn't mention also if the woman's pregnant, that's the best form of birth control there is. You can't get pregnant while you're pregnant. So if a woman's pregnant, that's the perfect woman to go on dolutegravir. What you have to worry about is her next pregnancy. The birth defects that have been possibly associated with dolutegravir occur within the first few weeks of development before people even know that they're pregnant, okay? So I wouldn't hesitate to use it in a pregnant woman. Just think about, well, 6 months, a year, 2 years from now, do we want to get her off it if she wants to get pregnant again? Hopefully by then we'll have more answers. I'd like to think that, we went through this with the Favrins, with the monkey.
Yeah.
It didn't turn out in humans. We'll cross our fingers and hope it doesn't turn out. So I think it's a relative issue. The other thing on this woman, I kind of lost track on the slides and so on. With her creatinine, if we're going to give her dolutegravir, that's fine, but I can't see giving this woman tenofovir until we know what's going on. There's a creatinine clearance of 53 mils, and then there's a creatinine, like it was over 1,000 micromoles per liter at some point. So yes. There was a mention of aminoglycosides and her hearing. I talk about aminoglycosides and her kidneys too. She seems to have apparently some hearing loss and obviously some significant renal loss. So, and lamivudine we think of as being like a really safe drug, but if you really have severe renal failure, we need to dose adjust the lamivudine also. And I believe, you should have 150 milligram tablets available. So I'd have to look up I've lost track on the labs what her creatinine clearance is, but she may end up going to an every other day lamivudine. She could take dolutegravir separately. And I'm looking at your formulary here, which one of your pharmacists sent me. You have Bacavir 300s available. So you can cobble something together that's renal adjusted or hepatic metabolism and really good. Although what she's on right now, if it's working, we don't know if she ever took any tenofovir, with her adherence problems. If she failed tenofovir, Bacavir is not a good choice because she's going to have a K65, which is a Bacavir, particularly if there's a 184 also, which may or may not have occurred. I think someone else mentioned it too. The Abacavirs might not be the optimal choice, but I think if we monitor the viral load closely, keep her on the Kaletra, we may be doing okay. If there's tolerance and adherence issues, switch to dolutegravir would sound fine. And as you mentioned, in her current improved but still quite precarious medical situation, not a good time to get pregnant. So independent of drug toxicity, I think a discussion about contraceptive and perhaps hormonal contraceptive should be discussed. And she's not on a Favrin, so we should be pretty good with hormonal contraceptives.
Thank you very much, Doug. Unfortunately, we are running out of time, but you point out something very important that I've had to answer on 70/40. If somebody has got renal dysfunction or we are not sure about the renal function, we cannot transition them to TLD because TLD contains tenofovir. Thank you very much for pointing that out, Doug. I don't know if we have any more contributions from the hub. Go ahead, Mary.
I have one reflection on this very complex case, and I'm just thinking that, in 2015 would have been the best time to appropriately manage this patient. And it sounded like there's a social situation behind that. And it just makes me think we need to strengthen our initial management and counseling of patients. I mean, if nothing else, to just remember this horrific case and, let that drive how we encourage patients to adopt same-day ART.
Thank you very much, Mary. I really like the way we've ended that. It's about adherence and counseling and reminding our patients because these things are very basic. You do not need to have a PhD to do them. However, the consequences of us not following through with adherence and counseling is that we end up with situations that are extremely complex. So Precious, what we'll do is we'll go to the TB lab and try to follow up and see what results we have. And then we'll be able to give you some results and make further recommendations. Thank you very much to all our spokes, our valued spokes. Thank you very much to everyone in the hub, and have a good day. We'll see you on next week, Monday. We are dealing with TB, HIV in the pediatric population next Monday at 14:30. We are now going to run the poll again, and there's an announcement from NOMSA.
Let's run the poll.
The poll. As he's putting up the poll, you can do them.
Yeah. Okay. Quite an educative session, and we look forward to all of you participating in the next sessions. I just want to make an announcement as we put the questions up there. You know, it will be very helpful for each one of us when we participate to actually enter our attendance in the register, because this will be helpful as part of continuing professional development. So we've been actually asking for all of you to have your register in the attendance and then send through the attendance immediately after the sessions. So I hope that all of us that have participated have registered, and you'll send through the register at the end of this session. So people are continuing to actually poll in, but I'll also continue to just say a few more things. The other thing that I would like to encourage each one of us that are practicing, this is a case-based learning that helps us to master complexity. So please do take advantage of documenting any challenging cases that you come across and send them through. And this is helpful because it is something that we use for learning opportunities for the rest of the healthcare worker community of practice. So I'd like to encourage you to continue sending through the cases. I think the polling questions are continuing, so continue. Interesting.
Okay. Okay. All right, just a quick one in the interest of time. So the first polling question was, according to Zambian ART guidelines 2018, on the management of TB in HIV co-infected patients with severe immunosuppression in ART-naive patients, ART should be started. What answer did we get from the poll?
So 50% say as soon as they can tolerate the medication.
So yes, that would be the best answer, as soon as they tolerate the medication or immediately. I have seen a comment somewhere where it says 2 to 3 weeks, but for people with a CD4 less than 50, really, you want to do that immediately. And also remember, sometimes when we let the patient walk out of the hospital, we have missed the opportunity to start ART. Okay, so as soon as possible, or when they can tolerate the TB medication, which can be even this, the following day or 3 days, depending on how they're looking. Okay.
The same day.
Yes, the same day. Okay, urine TB LAM, what did we get?
So most of them said they can't see the poll.
The poll, what was the answer for the next question?
Percentage.
I can't see.
This one.
Yes.
So most people actually, it was a split adult HIV positive patients who are severely immunocompromised, and any patient who's unable to produce sputum. That's
a nice one. That's B. So in this, in almost all the TB urine studies, it has been adult patients who are severely immunosuppressed, and never pediatrics. It was found to be useless in pediatrics.
Yes, and it's not for any patient who can't produce sputum, because if your CD4 is above 100, it's to put it plainly, it's not a very useful test. You have to be severely immunocompromised to benefit from a urine LAM, and you have to be an adult. And the last one?
So the last one was on DTG. It cannot be used in TB, HIV co-infected patients. The dose can be increased to 50 milligrams BD. What did we get?
I think there was a 50-50, but...
That's interesting, right?
Yeah.
So it could be used in TB, but the dose has to be increased to 50 milligrams BD.
Yeah, so both are correct, isn't it? We can use it, and it has to be double dosed.
Double dose.
It's very important to remember this so that we don't end up with cases like that, isn't it? Because sometimes it's iatrogenic. We cause it because we are not really looking up how to dose the patients. But I think thank you very much to everyone for the fantastic participation. Apologies that we lost Lewanika.
But thank you very much to Lewanika for that good case.
See you next Monday at 14:30 where we talk about TB and HIV in pediatrics. Thank you.
Thank you.
It's a wrap.